My name is Nicole Cipriani. I'm from the University of Chicago. I am a head and neck pathologist interested in diseases of the head and neck, thyroid, digital pathology as well. It's very, very great to be here in Mexico. Everyone has different ideas of how they practice pathology. Everyone sees different diseases, and the ability for us to exchange information not only about the diseases that we see, but how we diagnose them and how we practice pathology, I think gives each person and each party a much better understanding of the challenges that are out there in the world, because sometimes we can be very isolated in our own practice, and without really talking to others and visiting the countries, we don't really understand what people are going through. And I think patient care across the world, we should aim to have it standardized and aim to have it all, high quality, but acknowledging that there are differences depending on what country you're in, what city you're in, even what hospital you're in. I think we're potentially detecting cancers more because we are doing a lot of imaging of the head and neck for other reasons. So CT scans, MRIs, and a thyroid nodule is picked up. And then we are almost obliged to work it up and do a biopsy and see if there's cancer or not. Increased diagnosis is one, potentially due to increased detection for that reason. Two, I think there have also been once you detect it, increase in histologic diagnosis, meaning our threshold of diagnosing cancer has changed over time. And I think we are in a bell curve maybe where we were at a peak of diagnosing cancer a while ago because of our lower threshold for making the diagnosis on the tissue. But now maybe we're sort of coming down and realizing that some of these things that we thought were cancer maybe aren't. So I think we might see a slight decrease. Thirdly, whether there is some biologic or environmental factor in patients that is potentially causing increased carcinomas, I don't know. I've read a little bit about that there might be some changes in our exposures that are potentially giving us increased actual risk, but I think that's a lot harder to tease out in terms of the data. So I think there's probably all of those three things combined. For me, the sort of arc is, once a nodule has been detected and an ultrasound is performed to determine the radiographic features that put the nodule for being more at risk of being cancer. The gold standard for triaging these cases is fine needle aspiration biopsy, because it is very minimally invasive and it is good at detecting either the likelihood of something being benign or the likelihood of something being overtly, one of the more common cancers like papillary thyroid or medullary thyroid carcinoma. But then there's this whole gray area of in between. I can't tell if it's cancer or not. So I think FNA pathologically is an excellent screening test because it can pick up most benign and most malignant. But then in this intermediate area, I think that's where molecular testing comes in very importantly for detection and diagnosis of thyroid cancer, because we can, understanding the genetic background of benign versus malignant thyroid neoplasms, you can perform genetic analysis on these cells and put them in a category that is more likely of being benign or malignant if the actual cytology, the visual looking at the cells, doesn't tell you that. And so I think it's really powerful, specifically in thyroid, having that molecular understanding of disease that can transform an uncertain vision into a more certain molecular. We do this testing on our indeterminate thyroid nodules for molecular in our hospital, and it's been really interesting and I think useful to triage patients that way. The tobacco and alcohol associated carcinomas are more of the front of the tongue, the mouth, and sometimes even the larynx, right? Where the HPV, the virus cancers, are deeper, usually in the tonsils or in the deeper tongue. And so they present differently. Probably most critical screening methods for early cancer actually comes in, I've noticed, like dental practices, right? And so my dentist in the United States actually does a screening. He looks at my tongue, he looks at all of my oral cavity for early signs of patches or plaques that might represent more of the tobacco and alcohol related types of cancers that would present early and could potentially be cured with, you know, local resection if detected early. Conversely, the HPV cancers tend to present already metastatic in the neck, even though they have a good prognosis. And so similarly, screening with neck exams to detect any lumps, bumps, or enlarged lymph nodes is one of the ways that we more often pick up the HPV cancers. So honestly, patients themselves, primary care physicians, and even dentists, I think, have a really important role in knowing the early warning signs, whether they be in the mouth or in the neck, and appropriately triaging patients for biopsy to catch these things early. Unfortunately, if patients don't, you know, follow up or let things go unnoticed, or sometimes just have bad luck in terms of having a cancer that's very deep in the larynx and it doesn't present until they start to develop hoarseness, those can be tougher to detect because we don't have a way of visually seeing them, right, you know, like we do in the oral cavity. People always ask, are you scared about artificial intelligence and about digital pathology? But people ask the same thing about radiology, when radiology went digital. And you know what? We still have radiologists, and digital techniques do not, I don't think they eliminate pathologists. I think they supplement our workflow in terms of artificial intelligence flagging things for us to confirm rather than taking our job away. They may expedite our workload by screening things faster. They may help underserved countries in terms of, if you can't perform molecular tests, you could actually predict the molecular background of tumors based on just one hematoxylin eosin slide. And so we can use the tools that we have to help ourselves and to help the patients in perhaps cheaper ways. And so, you know, I've been working on some machine learning projects in this regard, in terms of, can we diagnose whether a breast cancer is going to be ER/PR positive, whether a thyroid tumor is going to have BRAF. All of these things are important just based on the glass H&E slide. So I think it's a great future for pathology. I'm not afraid. I'm not afraid of digital, and I think it will bring us closer together. Just, you know, back to the first question you were asking, I think it will help bridge that gap between the different countries in terms of what we can do for each other with the future of pathology.